Good morning, everybody, and welcome. I'd like to welcome you to today's event, a webinar presented by the Public Health Agency of Canada for healthcare providers on the seasonal influenza immunization for the 2021 to 2022 season. My name is Margaret Howarth-Brockman. I'm the Senior Program Manager at the National Collaborating Centre for Infectious Diseases. NCCID is funded by the Public Health Agency of Canada to provide knowledge translation and evidence for use in public health planning and policy. And we have been supporting the agency as well as other public health organizations with knowledge translation during the COVID-19 pandemic. I would like to acknowledge that NCCID is hosted by the University of Manitoba, and we are located on the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. There are just a couple of household items that I would like to mention before we begin. Today's event is being recorded, and the recording will be available on the NCCID website later on. The question and answer session today will be focusing on the seasonal influenza vaccine and antivirals. And so those are the questions that we will be answering today. You can like other people's questions and push them up in priority. And we will try to answer as many of those questions as possible, but we might not get to them all. The hosts will use the chat tab from time to time for extra communication to you. So please keep an eye on that tab as well. I would now like to invite our moderator for today, Annie Florence-Seelan, who is a registered nurse with the Public Health Agency of Canada. She will be our moderator for today, and we'll begin by introducing our speakers. Thank you, Annie.
Thank you, Margaret. Good afternoon. I would first like to thank the National Collaborating Centre for Infectious Diseases for their support in hosting this event and making it possible today. I would like to introduce and welcome our speakers for today's webinar, Dr. Robin Harrison and Dr. Jessie Pappenberg. Dr. Harrison is the Vice Chair of the National Advisory Committee on Immunization. She's an infectious disease specialist and a clinical professor at the University of Alberta in the Department of Medicine, Division of Infectious Diseases. She joins us from Edmonton, Alberta. Dr. Jessie Pappenberg is an assistant professor of pediatrics and an associate member of the Department of Epidemiology, Biostatistics, and Occupational Health at McGill University. He practices pediatric infectious diseases and medical microbiology at the Montreal Children's Hospital of the McGill University Health Centre. Next slide, please. Next slide, please. Please take a few moments to look at the disclosures for today's presentation. And next slide again. At the end of this webinar, you will be able to discuss the importance of seasonal influenza vaccination and COVID vaccination during the COVID-19 pandemic. You will be able to identify and address barriers to seasonal influenza vaccine uptake. You will be able to apply the National Advisory Committee on Immunization, or NACI's, recommendation on seasonal influenza vaccine use for the 2021-2022 season. And finally, to identify where to access NACI advice, antiviral guidelines, and other resources relevant to vaccination during the 2021-2022 season. Next slide. Over to you, Robin.
Okay, wonderful. Thank you, Annie, and thank you to our hosts, the NCCID and the Public Health Agency of Canada. So what we have organized today is to present 4 main topics to share with you, and I'm going to present 3 of them. So I'm going to present the bulk of today's presentation, and my colleague, Dr. Jessie Pappenberg, is going to be doing the same on Friday in French, but he will do the 4th section, which is on the topic of antivirals. So I'm going to start with our first. This is setting the stage. So this is some epidemiology. We're going to review the big picture trend here. What is the burden of influenza? And we're going to also talk about which populations remain at highest risk year after year with influenza. Next slide, please. So I'm going to ask you to just dial back in time. We are going to present these statistics from prior to the COVID-19 pandemic. I think everybody here will know there's been very little that was ordinary about 2020 or 2021 to date. And the influenza season falls into that category of not ordinary during the pandemic. So prior to the pandemic, even now we have surveillance, of course, for seasonal influenza, but prior to the pandemic, our numbers looked quite different than they did last year. So if you look globally every year, and there is some variation year to year, depending on factors like the strains that are circulating, whether there's a pandemic influenza, uptake of vaccine, we have the ability to change these numbers to a small extent, but on average, year after year, there are an estimated billion infections around the world with influenza. The tip of the iceberg, but it's the tip that impacts us all. And our goal is to prevent these parts that you see at the tip, which are the severe illness. This is illness that even leads to hospitalization and death. And so, you know, every year, 3 to 5 million people with severe illness and an estimated almost 300,000 to over 500,000 deaths from influenza. The estimated annual attack rate for adults is about 5 to 10% and even higher in children. When you focus on Canada specifically, influenza and pneumonia are ranked among the top 10 leading causes of death in Canada. And I'll just remind you that influenza, which is a virus, can be followed and predispose a person to a secondary infection with a bacteria, which can cause a bacterial pneumonia. And so these two things can be linked. In Canada, it's estimated that flu causes approximately 1,200, 200 hospital stays every year, 3,500 deaths. So this is a serious disease. What has been remarkable is that last year was not like all of these others. So I'm going to ask you to advance the slide, and we're going to talk a little more about this. So many of you, because I know we have a healthcare worker audience, will say, you know, there really wasn't much flu last year. And so just in case you didn't know, or if you want to quantify it, there really was not much flu last year. And some people might have said, well, probably because we weren't testing. We were so busy testing for COVID-19. But what this slide attempts to outline for you is that, in fact, our amazing laboratories and our clinicians assessing patients and so on were testing for influenza. In fact, more so than in years past. There simply wasn't influenza virus being detected. It wasn't here. So it was truly an unprecedented, remarkable season if you're looking through the lens of influenza. So on your left, on this slide, your bottom left, this picture is, or graph rather, is trying to show you the number of cases, rather influenza tests, not cases. So the average is the dotted line, and the gray showing you a bit of variability. This is over a period of seasons, the 6 seasons prior to our pandemic year. We would typically detect about 52,000 cases over that time period. If you look at the number of tests that were done, again, this is the bottom left, it was, you know, in the range of 200, 300,000 tests per year. And certainly we were out testing that up around 600,000 tests. So lots of looking for influenza in the 2020 to 21 season. On the right side of the slide, this is showing you the percent of influenza tests that actually tested positive. So again, the gray and the dotted line are meant to show you the average over the last 6 years. So like I was saying, typically 52,000 or more cases in a year. And last year, 69. So it's just incredible. The percent positivity never exceeded, you know, 0.1%. In years past, you might see anything from about 1 to 25%. So this was really extraordinary. We didn't see influenza last year. Next slide, please. And this really, you know, this wasn't just us in Canada, globally, and you can look for information globally or other countries through FluNet, the World Health Organization. But globally, circulation of influenza was at historically low levels in both the northern and southern hemispheres. And the key point I want to make, and we did this last year in September, October as well, is that we don't know what's going to happen now. And there are several reasons for that. I want to point out that most people with expertise in influenza will have a little bit of trepidation about trying to predict influenza. Some of my mentors will say you can't predict exactly what's going to happen with the flu, but there's certain things you can expect and we can prepare. So we can expect that as some public health measures are relaxed and as travel increases, because we know that travel is one of the ways influenza spreads globally, that we might see more influenza. We know from history that when influenza resurfaces, and we know that it does, it can come with a vengeance. So it's absolutely critical that we prepare. And because vaccine is our most powerful tool for preventing influenza, this picture here shows us why we really need to be prepared and ready for when influenza does return. There's a few references here for you that you might find interesting to read a little more about this. And I encourage you to think about this and just remember, because some may wonder about the Southern Hemisphere where they did not see a lot of influenza even in their season, which was this summer. What happens in the Southern Hemisphere doesn't necessarily predict what's going to happen for us. And so this is a very interesting time, and we will see, but we need to be prepared. Next slide, please. So many of you will know this very well, the symptoms of influenza. If you look at this list, you'll see the things that look familiar this year, because we've been talking endlessly about COVID-19, and many of these symptoms overlap. But I just want to remind you of the hallmark of influenza, which is the sudden onset. It is this abrupt onset that is quite typical of influenza, and not so with COVID-19. The COVID-19 clinical picture can be highly variable. Some people have sudden onset, but a lot of sort of waxing and waning, hide and seek. With influenza, people often describe feeling well, and then all of a sudden, or an hour later, the key is the sudden onset of high fever, cough, and a malaise. They don't feel well all of a sudden. So just keep that in mind. That is one hallmark of influenza illness. And many people say I had the flu, and they might be referring to a myriad of pathogens, not influenza. So it's important to keep our language precise when we're talking about influenza. It's really this syndrome. And of course, we confirm it with a test when we have uncertainty. Some people, especially children, can have a slightly different picture from the high fever, cough, and malaise, in that they might have nausea, vomiting, or diarrhea as part of their spectrum. And so that's important to remember as well. And of course, that also overlaps with other respiratory viruses, including COVID-19. Next slide, please. Influenza A and B are the main influenza viral strains. There are others, but those are the two that we focus on in humans that cause seasonal outbreaks for us. Influenza A are classified into two subtypes, and that's really based on the two surface proteins, the hemagglutinin and the neuraminidase. Of these, the real our bad pathogens, if you will, are three subtypes of the hemagglutinin, H1, H2, and 3, and two subtypes of the neuraminidase, N1 and N2. Since about the 1980s, influenza B has evolved into two lineages. The B in the nomenclature denotes this as influenza B, Yamagata, for where it was first described, and you see the year in there as well, but B Yamagata lineage and Victoria lineage. Remember from your textbooks or training that antigenic variation, which is termed antigenic drift, can occur within influenza A or any of the B lineage. Antigenic shift can also occur due to reassortment of genes, and that can cause abrupt major changes. And we've sometimes seen that with influenza A, and it can be a part of what leads to pandemics with influenza. Next slide, please. Every year, the vaccines are developed in response to some of the changes, this drift, and change in the strains that are circulating. So this is based on global surveillance observation. This is one of the reasons we do surveillance. The World Health Organization establishes which virus components to include in the vaccine for the Northern and Southern Hemisphere. This is typically done quite far in advance. So for us, this planning would have been, it's long done, so that the vaccines can be prepared. And you can appreciate the challenge last year with almost nothing circulating. Several influenza strains can be included in a vaccine. So the trivalent formulations would include 3 strains. Now we're fortunate we've got quadrivalent vaccinations, so we can include 4 strains, so 2A and 2B. So your quadrivalent vaccine is going to cover for 4 strains, and that those are determined each year. Viruses that are circulating within a population can sometimes change during the flu season. That's really unfortunate if it happens, because the vaccine may not work as well as expected. And so you will see some potential variation in effectiveness year over year. The health and age of a person can also affect how well vaccines work for that individual. So it is this drift that means we have new vaccines every year with our current technologies, and vaccine-induced immunity can also wane. And that's another reason that annual influenza vaccine is recommended, unlike other pathogens where you might only have, you know, a series at one point in time. We, as you know, we do this annually. Next slide, please. So the influenza vaccines work. There's no question about that, but they're not 100% effective. So they're not our very best vaccines in that way. And there can be this variability, but the key point is they work, and they are our best preventive measure for influenza. And there's continued work to try and improve them to have our best protection possible. But what this slide tries to show you, if you look at the graph on your right from 2004 up until 2019-20 season, they're showing you here vaccine effectiveness estimates, and this comes from the Canadian Sentinel Practitioner Surveillance Network. And you see the variability. These lines are moving around. Some years weren't as strong, but you know, things settle out around 60–70% a lot of the time. And so we tried to sort of highlight some of the reasons for why you might see this variability. Next slide, please. So the composition for the current season, these are the World Health Organization recommendations, are an A pandemic-like H1N1 strain, A Cambodia H3N2, and then the 2B lineages rather. Trivalent vaccines have the Victoria lineage, and of course the quadrivalent allow you to have the other B strain there, or lineage rather. Next slide, please. So with what we know about the epidemiology for influenza in mind, actually, we'd like to have everybody immunized. Why take any chances with a pathogen that has such high stakes? We do have a national stated goal, though, of at least 80% of those at higher risk of complications from influenza. So we want at least 80% of people vaccinated. And so on this slide, what we're attempting to show you is that we really do still have work to do to reach that target. And so I actually think this is quite interesting. If you look at seniors 65 plus, uptake is the highest in that age group, about 70%. So close, although not technically at that 80% benchmark. And the nice thing about this slide is that you can see 3 years in a row here. In the Southern Hemisphere, early on, we heard from other countries that uptake for influenza vaccine was unprecedented. People were rushing to get vaccine. They didn't want influenza on top of COVID-19. This looks a little more moderate here, but so it wasn't higher or lower, but you see the trends. In those 18 to 64 with chronic conditions, only about 40% year after year, a little lower in those without chronic conditions. And then if you pool all adults combined, we're sitting at about the 40% mark. So we have work to do collectively. Next slide, please. Key takeaway is that vaccination can help prevent influenza and its complication and transmission to others. Although people usually just recover fully in about 7 to 10 days, it can lead to severe complications, hospitalization, death, and strains on our system, and obviously tragedy for families when you lose someone to a communicable disease. Annual vaccination is required to provide our best protection possible against these viruses. And through the 2021 season, the number and percentage of laboratory tests that were positive for influenza remained exceptionally low, truly extraordinary. But it is likely there will be an increase as we move through the pandemic and as we reopen, and particularly as people begin to travel and public health measures and personal measures are modified because of the power of our COVID-19 vaccines. During the pandemic, it's important to minimize everything that we can related to both influenza and COVID-19. Having two viruses at once, for I think obvious reasons, is really not something that we look forward to. And so we're trying to obviously take all the steps we can to be extra careful this year. Next slide, please.
Thank you, Robin. We're trying in this new formula this time with you participants to engage you into the webinar. So we have a poll that you'll see come up on your screen. I see it already on mine. This is a true or false question. So we wonder, seniors who are 65 and older and adults 18 to 64 years who have medical condition are at increased risk of influenza-related complications and hospitalization. This is a multiple choice, so yes or no, true or false. I'm going to give you a few seconds to answer. Can we see the results of the poll? Excellent, everybody got this one. Next question. Wait for it, it's coming. I'm gonna start reading it while it makes its way to you. So primary healthcare providers, due to the nature of their work, may inadvertently transmit influenza to those at high risk through their activities. True or false? Since you're all good, we're not going to take too much time with this. Please show the results. And again, we have most of the people who got this right. Thank you so much. Back to you, Robin.
Great, thank you. Okay, so thanks everyone. So we're going to talk now about what we can do about not meeting our targets and what we can do to increase uptake of immunization. So next slide, please. So what is the role of a healthcare provider in this? So there's some things that might be particularly interesting this year. I think one of the good things to come out of the COVID-19 pandemic is just the sheer level of engagement we have from so many people and the way people are connecting across specialties and disciplines. We have people very, very interested in vaccines at this time, just generally. And so I think they're going to ask great questions. So people may want to know what kind of vaccine their flu shot is this year. You probably will tell me that people didn't ask that before. It was just the flu vaccine. But they may want to know what type it is because there's so much discussion about the various COVID-19 vaccines. So it might be good to be prepared with what you're offering, which ones are available. And the National Advisory Committee on Immunization Guideline is a good place to find that information. It's organized in a table for you. There's also a table that shows the vaccines that are authorized by Health Canada. And that might be good to just have at hand in case these questions come your way, so that you can feel confident answering, looking it up, and so that they have confidence that these are things that that we know and talk about. So be prepared to answer. Remember your audience. So of course, not everyone in front of you comes from the same background. It's important to deliver information in a culturally sensitive way and in an age-appropriate manner. So if you have someone who may not be able to read, it's important to know that up front. You're not going to hand them a pamphlet, you're going to walk through it. If their first language isn't English or French, then that might affect the way you explain or answer their questions. And so just obviously keep those things in mind. And remember or consider the various backgrounds that people come to us with, especially when they're interacting with healthcare. Some of us have interacted with healthcare a lot, and that may have been a good or bad experience for us. Some are aware of racism and systemic racism and things that could make them feel threatened or nervous. And it's important to sort of think a bit about those angles as well. So really tailor your counseling to the people in front of you. Provide information on possible impact of the disease severity and focus on that rather than the overall effectiveness of the vaccines, which, as we highlighted, can really vary year to year. Focus on the goal that we have, which is to prevent severe disease and death, and how we're going to get to that goal collectively through community immunity and protecting ourselves individually through vaccines. Next slide, please. And so again, on this point of just really trying to tune into the person in front of you, counseling about vaccines is a really good opportunity to get to know someone a little better or connect. There is a model that you can use to help explore where someone might be coming from when you sense that they are hesitant. So this 5C model, it's called, summarizes some of the key factors that are that commonly influence vaccine hesitancy. And I hope everyone remembers there really is a spectrum, those that are very much in favor of vaccinations generally, and those who may declare themselves as being against vaccinations at the other end of the spectrum. In between, there are a lot of people that may be hesitant, and they've got a lot of room to move along that spectrum, and maybe particularly receptive to what you can offer. So the 5Cs tells you that some people come hesitant with these different lenses, if you will. So confidence, maybe the level of trust in the effectiveness and safety of the vaccines or the systems that deliver it, or of those who establish vaccine policies just is low. Maybe they aren't confident in those things. Complacency. Some people have a perception that risks of vaccine preventable diseases are low and vaccines aren't even necessary or not necessary for them. Convenience, the extent to which vaccines are available, affordable, accessible. Do you have to take time off work? Can you actually get there, understand what these vaccines are about? That can really affect how likely you are to obtain a vaccine. Calculation, you will meet individuals who engage in extensive information searching and evaluation of risks, infection versus vaccine, and that can be a bit overwhelming, or it can lead to uncertainty. And this is also where a lot of misinformation can feed into complicating the picture for those who want to do the right thing for them, but are feeling hesitant and uncertain. And finally, the 5th C is collective responsibility. And this is the extent to which one is willing to obtain their vaccine and consider the impacts to others around them. And this particular theme may resonate more with some communities than others. And so it's good to be sort of attuned to where that sense of collective responsibility is really strong in some communities. And that might help a person see, if my goal is to be a good person in my community, that this can be actually part of that, even though I was uncertain. Complacency, the second C I want to just highlight, is quite common amongst younger individuals. And we saw on that bar graph that young individuals without comorbidities, the uptake is about 30%. So this is where if you sense that that's an element to someone in that age range, you can speak to them a bit about the science of some of the other things beyond just death, because it is true that death in a younger age group without comorbidities isn't as likely as other age groups, but you can speak to some of the other impacts of influenza illness, time lost from work, time pay, impact on others, and also what it's like to recover from an illness that some may not appreciate. And there's some science to support that, and that might help people. Next slide, please. So once you've identified a person's knowledge, attitudes, beliefs, try to explore these things, we can better look into what can be done. So this slide just presents to you survey results that give you some of the highlights of when people are surveyed in Canada, what types of themes emerge. And one thing I want to really highlight here is that many respondents agreed that the opinion of their healthcare provider, family doctor, general practitioner, nurse practitioner are really important part of their decision for whether or not they'll obtain the flu shot. And so I want us to all just keep that in mind. Next slide, please. So these are some techniques. Once you've explored what might make a person feel hesitant, these are some tools that you can use to try and help support the person. The first one is to use presumptive statements. So the idea here is that it really ought to be a social norm to obtain the protection we can from communicable diseases, and that includes vaccination. So opening with questions like, where have you decided to book your influenza immunization this year? Or do you plan to go with your child to obtain your vaccine when you go this year? Can be helpful to just sort of set the norm that, you know, I'm planning to go and I'll be booking my appointment ahead of time. And let's talk about vaccine. It can be a good way to open the discussion. Using your own experiences can help. Activate the right types of emotions. So it's important, the research shows us it's important not to be judging or labeling, or you should do this, should have done that, but be really intentional about the positive emotions that we can tap into, about the hopeful feelings we might have about the power of vaccines that will get us safely through an influenza season. Maybe we can improve the statistics I opened this webinar with when we get into a community of protection, and what we can do to keep our families safe, especially where we have the overlay of a pandemic with another respiratory pathogen. This primer that is mentioned on the bottom of the slide is excellent. I strongly encourage you to look at it. This is from the Public Health Agency of Canada. There are lots of good tips, including sample scenarios and sample phrases you can use. Next slide, please. Hey, Annie.
Hi, and adding to what Robin just said, the deck, the presentation for this webinar will be available online, and all the hyperlinks that you see on the slides are going to be available for you to click on, so you can actually find the resources and all the sources that we refer to throughout this webinar. Now, the next poll. So according to the 2020-2021 vaccine coverage survey, so this is a survey that wasn't published, but we gave you a few of the highlights already. So what percentage of the respondents agreed that the opinion of their healthcare provider is an important part of their decision in getting the flu shot? Are A, 26%, B, 52%, C, 74%, or D, unknown, because we don't remember. And please give your answers. While you enter your answers to the poll, I wish to remind you that you have a Q&A tab in Zoom that you can use to ask your questions for the presenters on the topic of the influenza vaccinations. So we will be moving in a bit into the Q&A session where we can actually address your questions. Okay, thank you. So what the results are for this poll? The answer is 74%. So your role as a healthcare provider is extremely important in having those discussions about vaccine confidence and flu vaccine uptake. Thank you. And next slide, and back to you, Robin.
Great, thank you, Annie. And so that is a Canadian survey, and so those results are applicable to our context. So this is the final section I'm going to present before handing it over to my colleague, Dr. Pappenberg. What I'm going to share with you here is what you can expect in the National Advisory Committee on Immunization recommendations, not what you can expect, they're already published, but just a walkthrough of the new parts, because I know many of you will have seen them from years past, and so you probably know that we build upon these recommendations each year and incorporate new evidence as it comes, or new vaccine products. Next slide, please. So the National Advisory Committee on Immunization, as Annie mentioned, is abbreviated and referred to as NACI. This is an expert advisory body that provides independent advice to the Public Health Agency of Canada on the optimal use of vaccines in Canada. So they set the national stage for vaccine use in Canada, and the recommendations come at the level of the individual and also vaccine programs. Provinces and territories are responsible for the immunization programs and the policies within their province. And so sometimes, so what you see is sort of NACI positioned here in the middle. You have Health Canada, which is the regulator, approving vaccines for use in Canada. NACI provides recommendations and factors in evidence, ethics, equity, feasibility, acceptability, and makes recommendations that can be used by provinces and territories and to you as healthcare providers reading the information. And so those recommendations are on the optimal use for our Canadian context. Every year, NACI issues a statement on seasonal influenza vaccine, and the Canadian Immunization Guide, which you'll be familiar with, the recommendations for influenza are incorporated into this statement. So the two are together at the moment in one statement. So the last several years you have seen this pattern. I just wanted to highlight that this can be used as your Canadian Immunization Guide on the topic of influenza vaccines. In the last year, NACI also provided recommendations on using influenza vaccines in the context of the pandemic. And so NACI had input into guidance that you see on the Public Health Agency of Canada website, and those are also good resources available to you. Next slide, please. The first recommendation applies to who should receive an influenza vaccine. So the recommendation from NACI is that Canadians and people living in Canada 6 months of age and older who do not have contraindications to the vaccine should receive the annual influenza vaccine, particularly people who are at high risk of influenza-related complications or hospitalization, people capable of transmitting influenza to those at high risk, and people at high risk of severe COVID-19 related illness. And then there's just one or two other groups, and I'm going to walk you through what those are. Next slide, please. So people at high risk of influenza related complications, the easy way to remember this is those at the extremes of age, pregnant people, and not just extremes because it's adults 65, which is not extreme, but 65 and older, but also adults, with frailty, including those who are living in congregate settings, nursing home, for example. And I don't know if I mentioned pregnancy, but if I didn't, I absolutely should. So pregnant people, extremes of age, those over 65 and with frailty, high risk health conditions, those are defined, and this list is fairly extensive. So it's cardiac or pulmonary disorders, diabetes, cancer, immune compromising conditions, renal disease, anemia, and hemoglobinopathies, those with neurologic or neurodevelopment conditions, those with elevated body mass index, and this is defined as over 40, children 6 months to 18 years undergoing treatment for long periods with aspirin because Reye's syndrome is a risk with influenza and those taking aspirin. So if you're interested in more details on some of these, if you look at the statements from NACI through the years, you can see where some of these have been updated, and this list continues to be worked upon year after year, and you'll see changes to come as we continue the influenza surveillance and as researchers continue to inform this. Next slide, please. People capable of transmitting influenza to those at highest risk. Well, this includes healthcare providers and other care providers in facilities and community settings. And so, the same themes here emerge with influenza as they do with COVID-19. When you're in close with repeated contact, you can appreciate the risk. And so this is also outlined in the guidelines. And it is also true that through these occupations where people can transmit infection, for example, from a healthcare worker to a patient, they also can be at risks of infection themselves through their occupational setting. Of course, we try to mitigate that through personal protective equipment and screening for illness, staying home when we're sick. All those things are important and they definitely help. But we know this risk is here, and so this is yet another reason to be immunized and for all of these groups to be immunized. Next slide, please. The people at risk of transmitting also include household contacts of those who are particularly vulnerable. Again, it's that close contact, and those providing regular child care to children who are very young, because those children are particularly vulnerable to severe outcomes, as we've mentioned. Next slide, please. One thing that we still need to learn more, we as a scientific community, we still need to learn more about is whether there's going to be co-infection with influenza and SARS-CoV-2 virus, the virus that causes COVID-19, and what's that going to look like. The absence of influenza has been curious, partly from, as we talked about, the measures that are in place, and you can wonder about viral interference and other things that have led to this over the last season, but we know influenza will resurge, and we will still have more to learn about the impact of two viruses at once. It's rare, but we do sometimes see co-infections, and so we want to keep this in mind, and certainly one or the other, certainly those who are at high risk of severe COVID-19 related illness are going to be at very high risk with influenza circulating too. And so it's really important to keep in mind how serious it is, the prospect of having the two viruses together at once. Next slide, please. The other group that was mentioned are those who are providing essential community services that we rely on, and also that are interfacing with the public a lot, and people in direct contact with poultry infected with avian influenza during the culling operations. And the idea is here is that you don't want to allow any opportunity for that reassortment that we talked about and mixing of strains between avian influenza strains and human strains. And so vaccination is recommended for those individuals yearly as well. Next slide, please. The schedule, as you know, this is a one dose. All of our current vaccine products are one dose schedules, with the exception of children in their first dose. So it's 2 doses at a 4-week interval for those who've never had an influenza vaccine before, up to the age of 9 years. Next slide, please. So in the new statement, what you'll see is that all seasonal influenza vaccines, including the live attenuated influenza virus vaccine, may be given at the same time before or after administration of other vaccines, including COVID-19 vaccines. That is a recent change. Early on, when the COVID-19 vaccines were new, it was recommended that these vaccines be spaced so that the post-surveillance safety monitoring that happens with any new vaccine can be separated from vaccines, and because there were some uncertainties. But now, with so many vaccine doses having been administered for COVID-19, time for observation and research that is still ongoing on concomitant administration, the current recommendations are that yes, you can receive your influenza vaccine at the same time as a COVID-19 vaccine if that were to apply to you and to other vaccines that you may need. That guidance was already there for our more long-term established vaccines in the Canadian Immunization Guide. The other item that is new is the types of vaccines. There's been some changes and some age indications. They are listed for you at the end of the presentation. When you have these printed afterwards, you can look at this, but I'll just take you through to the next slide, please. And highlight this. So we have standard dose quadrivalent inactivated influenza vaccine, Influvac Tetra, as an option for the quadrivalent inactivated vaccines for individuals 3 years of age and older. High dose is now quadrivalent inactivated influenza vaccine. So Fluzone high dose quadrivalent is now added to the repertoire for adults 65 years of age and older. And there is a new recommendation and a summary of supporting evidence for the mammalian cell culture-based vaccine. This is another inactivated seasonal influenza vaccine. It's called Flucelvax Quad. And there's a whole dedicated NACI statement on this if you wish to review the background behind it. And it's noted here on the slide that Flucelvax Quad more recently was authorized by Health Canada for use in people just 2 years of age and up, and that's currently under review by NACI as well. Next slide, please. So who should not receive the influenza vaccine? The good news is there are very few contraindications for influenza vaccines. People who've had an anaphylactic reaction to a previous dose should not receive the influenza vaccine. People who've had anaphylactic reaction to any of the vaccine components, with the exception of egg. Egg allergy is not a contraindication to the influenza vaccines. People who've developed Guillain-Barré syndrome within 6 weeks following a previous influenza vaccination where there isn't another cause found. If there's another cause found, that's a different story. GBS can be caused by a myriad of things, including influenza infection. So it really needs a fulsome review, but these would be the conditions where influenza vaccine would not be advised. Next slide, please. Who should not receive a live attenuated influenza vaccine? So in addition to the contraindications on the preceding slide, it also shouldn't be given to people with immune compromising conditions. This, of the influenza portfolio, this is the only one that would fall under the live category. So this one is not advised for immune compromising conditions. The one exception, which you may remember from a statement from last year, is that children with stable HIV infection who are receiving antiretroviral therapy and have adequate immune function can receive this vaccine. So it is an option for those children. Severe asthma would be a reason not to give the live attenuated influenza vaccine because of the risk of exacerbating breathing difficulties. And so that also applies to anyone who had medically attended wheezing in the 7 days prior to the proposed vaccination. Those with stable asthma and without acute respiratory problems could receive LAIV. Next slide, please. It's not for children less than 24 months. And for the same reason that we spoke about Reye syndrome being a risk with influenza infection, it's not recommended for children 2 to 17 who are receiving long-term aspirin or aspirin-containing therapy. Also not recommended for people who are pregnant. There is a lack of safety data for pregnant people. It is not contraindicated in breastfeeding. It's noted there's limited data in lactating individuals, but no reason to think that it would be contraindicated. Next slide, please. And just a reminder that this particular vaccine shouldn't be administered until 48 hours after antiviral agents that are active against influenza. And if those agents are needed, it shouldn't be administered until 2 weeks after LAIV, unless of course they're needed, in which case you go ahead and give treatment people need. So if the antiviral agents are administered in that time frame, then revaccinations should simply take place thereafter, or you could give the injectable inactivated influenza vaccine at any time point, and that would be fine, and it wouldn't expect to impact its function. Next slide, please. This is the type of table that you can find. You can read the whole NACI statement or the CCDR summary. This table, it looks a bit busy at first, but you might want to, if you're expecting those questions from people about what type of vaccine did I get, you might want to familiarize yourself with the abbreviations. These standard abbreviations, new just a couple of years ago, are going to be used year after year. So IIV 3 for trivalent, 4 for quadrivalent. IIV means inactivated influenza vaccine. SD is standard dose. You can see there's CC for cell culture, adjuvanted, high dose. And so you see the high dose, the adjuvant, these are recommended for your over 65. These are attempting to really bolster the best immune response that you can. And then you see the LAIV highlighted for children, really. So this is a reference table available to you. Next slide, please. The key messages are that it's important to discuss the importance of influenza vaccines with our patients, and especially if they're at high risk of complication or transmitting flu. And we've reviewed those categories together. Seek to understand the factors that are preventing people from getting vaccinated by starting with some space and time and respectful, culturally sensitive, age-appropriate discussions, get to know people, and then think about the diverse factors that really make each person different in this regard, and maybe consider that 5C model to try and explore where people might be coming from, and some of the tools we shared to try and help everyone reach the goal of reducing the impact of influenza this year. Next slide, please. Okay. The key messages and the recommendations, we've done a sort of a brief walkthrough, and the links, as Annie mentioned, you can click on afterwards when you have the slide deck yourself to get to these documents that will summarize what we've discussed. Next slide, please. Okay, I'm going to sign off.
Hi. Thank you, Robin, so much for taking the time to present with us today. We're moving on to our last poll of the event to test your knowledge on which one of the following is the live attenuated influenza vaccine, intranasal vaccine, contraindicated for. So who should not be receiving it? Choice A would be the people with a history of stable asthma. Second choice, people who are pregnant, or finally, children with stable HIV infection who are currently being treated with HAC therapy, with adequate immune function. Please answer your poll. I'm going to give you a few more seconds, and please show the results. And there we go. At this time, is with the people who are pregnant that we do not recommend that they receive, that they are offered the live attenuated influenza vaccine. Thank you. And for the final part of the webinar, I would like to invite Dr. Jessie Papenburg to speak about the antivirals.
Hi, thanks for having me. And we just have a few slides to discuss antiviral agents. And as we've discussed up until now, absolutely influenza immunization is the cornerstone of prevention. But we do have some options and some choices to make when a person develops an influenza infection. Next slide, please. So are antivirals recommended for the treatment of influenza? Because we know actually that most people who develop an influenza infection will become only mildly ill, and most don't require any sort of medical care or antiviral treatment. But some people who do get the flu do have risks or are very sicker than most. And in these cases, antivirals can be taken because they've been shown to decrease the duration of symptoms and decrease the risk of severe outcomes of the flu. So healthcare providers can consider prescribing antiviral drugs to reduce influenza morbidity and mortality. And that's especially true for people who are at higher risk of severe outcomes from influenza or who are severely ill, either sick enough to be hospitalized or having progressive illness as an outpatient. So our choices on whether or not we should be prescribing antivirals will depend on a number of factors. And certainly the patient risk stratification is very important. The relevant history in terms of mostly the progression of disease. And finally, the duration and the severity of symptoms. Next slide, please. So currently in Canada, there are 4 influenza antiviral drugs that are approved for use for the treatment of influenza. But only 2 of these are currently recommended because the last 2 are not yet marketed in Canada. So oseltamivir and zanamivir are both neuraminidase inhibitors. So they block the function of one of the 2 surface glycoproteins of the virus, the viral neuraminidase, which is essential for viral replication. Oseltamivir, also known as Tamiflu, is an oral capsule or a liquid suspension. It's been approved for use in persons 14 days of age and older, and there's a generic version available, and it's the most widely used influenza antiviral. Zanamivir is an oral a powder for oral inhalation through a plastic device similar to a disc-haler device that some asthma products are administered through. It is approved for use in children 7 years of age and over and in adults. Now, the reason for this age cutoff is that it does take a certain amount of coordination to be able to properly administer by inhalation. Hence, it's not approved for use in younger kids. It's not recommended for use in patients with reactive airway disease, such as asthma or COPD, because it can provoke an exacerbation of these illnesses. Now, briefly, peramivir is the only influenza antiviral that's available intravenously. It can be obtained from Health Canada on special access, and it is also a neuraminidase inhibitor with the same patterns of resistance and susceptibility as zanamivir or oseltamivir. It's approved for use in persons age 2 and older. Finally, the newest and first-in-class agent is baloxavir marboxil, which is a polymerase inhibitor. So it blocks a different important and essential step in influenza virus replication. It's notable in that it's an oral tablet, but it's given in a single dose. As opposed to the neuraminidase inhibitors that require a 5-day course of therapy given twice a day, baloxavir marboxil is given in a single dose, and it's approved for use in uncomplicated outpatient influenza in person 12 years of age and above. Unfortunately, it's not yet marketed in Canada, so not yet currently available. Some of you may be familiar with, sorry, just go back to that slide, yeah. The first ever class of antivirals developed against influenza were the adamantanes. So amantadine was available in Canada, is still available in Canada, however, is not recommended for treatment or prevention of influenza because all circulating viruses, whether they be H1N1, H3N2, or influenza B, and influenza B is actually intrinsically resistant to the adamantanes, and the circulating H3N2 and H1N1 viruses are also resistant. So really, it is not suggested that you use adamantanes for the treatment of influenza. Next slide, thanks. So some general principles as presented by the Association for Medical Microbiologists and Infectious Diseases Canada Influenza Working Group and their recommendations for the use of antiviral drugs are that antivirals should be initiated as rapidly as possible after the onset of illness, as it's been shown in both randomized controlled trials and in observational studies that the benefits of treatment are greatest when you initiate it as early as possible, ideally within 12 hours of symptom onset, but the RCTs were performed within 48 hours of symptom onset. Now, if antiviral can and should be initiated, even if the interval between illness onset and starting the drug is greater than 48 hours, if the illness is severe enough to require hospitalization, if it's progressive, severe, or complicated in the outpatient setting, and that is really an influenza pneumonia where we're talking about, or if the individual under consideration for treatment is from a group that is at high risk for severe disease. And Dr. Harrison went through those high risk groups and the comorbidities that are associated with them. So, so ideally within 48 hours, but you can consider and is recommended to be used under certain circumstances if the interval has been longer than 48 hours. Next slide. Now, otherwise healthy patients with relatively mild self-limited influenza are not likely to benefit from neuraminidase inhibitor therapy if it's initiated more than 48 hours after the illness onset. So it is not recommended in that context. Now, patients who are not given antivirals should be advised of signs and symptoms of worsening illness that might warrant reassessment and reevaluation from a medical perspective. Treatment duration is routinely 5 days, twice a day with both oseltamivir and zanamivir, but in certain circumstances, it could be continued longer than 5 days if clinically indicated as in a very severe illness, critical disease really, or in immunocompromised patients that might have a longer time to clearance of infection. And you can find these recommendations either in the foundation document from AMI Canada that was published in 2019, or every year there is an update that's being published again in the Journal of Association of Medical Microbiology and Infectious Diseases. And that update for the 2021-22 season should be available shortly. Next slide. And that's actually all I had to say on antivirals.
Thank you, Dr. Peppenberg. So I wish to bring to your attention that there's other sources of information where you can obtain information on seasonal influenza, so promotional products, as well as products to enhance your knowledge as a healthcare provider on the seasonal influenza vaccines. Different posters can be downloaded on canada.ca. You see all the hyperlinks that are there. We invite you to follow us on the different social media platforms that are indicated here, as well as to download the mobile guide, which is a seasonal influenza vaccine summary that is based on the NACI recommendations for this year's vaccine. Next slide. We have mentioned some interesting data earlier about based on the Flu Watch numbers that have been gathered across Canada. Flu Watch is a sentinel network within Canada that feeds also into a global sentinel network of flu watching. So you can register either as a healthcare professional to enter the cases of ILI that you observe in your practice, or as well as an individual. You can register as yourself or as a family to report any flu symptoms that you may experience during the season. The links are down there for your consideration. Next slide. And so with this, we move on to the question and answers session. But right before, I wish to thank again NCCID as well as the speakers to have taken the time to host and to present for us today. A reminder that a recording of this presentation will be available online along with a download for the slides on the site of the nccid.ca after the event. And upon exiting, you will be invited to complete an evaluation survey for this event. So we kindly ask you to complete that survey and appreciate your feedback if you do so. And so as we move on to the Q's and A's periods, I see we have a lot of questions. We don't have a lot of time left. We will try to address very quickly a couple of those questions that are there. we will use the questions that are there to inform future products that we have to inform you on the flu. And there we go. Okay, so what do we have? We had a question that came up. So how do we combat healthcare provider who give misinformation about vaccine, thus using the trust in the healthcare providers in a negative way? Whoa, that moved a little bit. To promote, to push clients away from vaccination. So for this particular question, I'd like to just call in Stephanie Elliott, who is our resident vaccine confidence expert. She wasn't one of the speakers, but we wanted to bring her along for this type of question. So thank you, Stephanie. And briefly, so we can ask another question to Dr. Harrison afterward. Thank you.
Sure, Annie, thank you. So your question is great, and it highlights the importance of really being trustworthy as healthcare providers, of really earning that trust. So I think some of the best things you can do as a healthcare provider is for you personally to share really good information, not just with your patients, but also with your colleagues. You play a role in building vaccine confidence among your colleagues. So and also remaining aware of what misinformation is out there circulating and get ahead of it, because just seeing that information for people can challenge your vaccine confidence. So if you know that something's circulating, get ahead of it, talk about why it's not valid information. And if you notice that your colleagues are spreading misinformation, try calling them in instead of calling them out. So rather than engaging in arguments, especially on social media, you can ask them to chat about where they got their information and offer to share better information with them. There's no perfect way to avoid it, but you can play a role in building confidence in your colleagues. So thank you for that question.
Thank you so much, Stephanie. The next question will be for Dr. Harrison. So what are the efficacy rates differences between the standard dose and high dose for the 65 years and older people? What would be, and how much, so in summary, how much more effective is the high dose compared to the standard dose?
Okay, thanks for that question. Yeah, it's a really good question, and it's actually not as easy a question to answer as you might think. So what I can tell you is that there is ongoing work to look at actually all of the vaccine products in that. I think this question was in the elderly population, and that's where you're seeing the recommendations for use, to try and get a sense of all of the voluminous literature on this topic, and particularly where vaccine products aren't necessarily compared one to the other head to head, but to other things like trivalent standard dose and so on. So there is work ongoing to try and compare all of them to get a sense of how much benefit will you get in that older population, and then there's lots to consider about why one vaccine might be the strongest choice for that age group. So what I can say is that we know there's this concept of immunosenescence in older people, that immune systems don't respond in the same way that they did when people were younger. And so that's where this idea of increasing the dose comes in, or that you also have adjuvants and other things that are designed to try and trigger the immune system in different ways, and so these do have benefit in older people. Quantifying the degree of it is a little more challenging. And yes, I think I see now in the chat here, there is some variability across jurisdictions, and that's part of the reason why, and that's why we're also trying to organize all the evidence to present it in sort of a fulsome way.
And I would just add to what Robin is saying, in that obviously there's the individual benefit, but there's also the question at the population level, and there are differences in cost between the high dose vaccine and the standard dose vaccine. And cost effectiveness studies have been done, but with not necessarily homogeneous results. So that certainly comes into play when jurisdictions are deciding what goes into their free program.
Yeah, definitely. And so you can kind of add economics to all of the other considerations: the ethics, the equity, the feasibility, the acceptability, and so this is work that is ongoing.
Thank you so much for those answers. Unfortunately, we're running out of time to answer more of your questions. I acknowledge there's a lot of very good questions, but we will have to move on to the closure of this webinar. I thank you so much, all of you who participated in this webinar to make it happen today, and for all the attendees who took time to be with us. Special thanks to Dr. Harrison and Dr. Peppenberg for speaking and providing expert advice to us today. Again, the recording and slides will be available online at nccid.ca, and please complete an evaluation questionnaire upon leaving this webinar. Next slide. So you will see in the webinar download that there's a few more slides that will be available for you to consult that we didn't have time to address today. So we invite you to go and consult these details after the fact. We thank you so much for being there and wish you a safe and healthy influenza season. Have a great day. Thank you.